So you've been referred to have a hysteroscopy. I'm Dr. Gail Busby, consultant gynecologist, and I'm going to talk you through what to expect from this procedure. So you've probably been referred for one of various reasons. Perhaps you've had some abnormal bleeding. Perhaps someone has seen what they think is a polyp, which is like a skin tag of the lining of the womb on an ultrasound scan. Or perhaps there's a thought that you might have fibroids within the cavity of the womb. Or maybe you've had miscarriages, or for some reason there's a suspicion that your womb shape is slightly different. These are all reasons why you might have been referred for a hysteroscopy. In this video, I will explain what a hysteroscopy is, how it's undertaken, and what your choices are. So, first of all, what is a hysteroscopy? A hysteroscopy is a camera test into your womb where we literally look inside your womb through a telescope called a hysteroscope. And this is an example of a hysteroscope, and this is what it looks like. There is the long end that passes through the vagina, through the cervix or neck of your womb, and then there is the eyepiece, and we look through that. This attaches a light lead so that we could see inside. As you can imagine, the inside of your womb is pretty dark. The hysteroscope is connected to a camera, and then the camera displays the image on a screen. And if you have this done as an outpatient, you can look at the screen yourself and see what the inside of your womb looks like. So the procedure entails us threading this narrow camera through the neck of your womb. Attached to the telescope is fluid, and what we do is we instill fluid through the telescope into the cavity of the womb to stretch the cavity out so that we can see inside. Because normally the womb isn't open, it's closed down. So if we just stuck the telescope in there, we wouldn't be able to see anything. We'd just be lost in the womb lining. Usually, and depending on the reason for the hysteroscopy, we will take an endometrial biopsy, which is a sample of the lining of the womb, and that is commonly done for abnormal bleeding, where we want to rule out that there are any suspicious findings in the lining of the womb. The endometrial biopsy is done with this device called an endometrial sampler. And again, it's got this long bit that goes through the vagina, through the cervix, into the cavity of the womb, and a syringe at the end through which we suck up the lining. That goes in a pot and that goes to the lab. Now, you mustn't let these instruments scare you. I know they look really long, but that's because they need to go through the length of the vagina before they even reach the cervix. Then they go through the cervix and then they go into the cavity of the womb. The duration of a hysteroscopy, so the duration of a diagnostic hysteroscopy, which is what I'm talking about today, which means we're having a look, we're looking to see what inside looks like, and we're taking a biopsy, a sample. So the duration of a straightforward hysteroscopy is about 5 minutes. Sometimes when you look inside, there may be a fibroid or a polyp in there, and this eventuality is usually discussed with you before you have the procedure. And we may go on in the same sitting to remove the fibroid or the polyp if this is thought to be clinically appropriate. Of course, if it's more than just looking, so we're removing something, then the procedure takes a little bit longer. Okay, so what are the risks of hysteroscopy? So I've explained what we're going to do. So we're going to thread the narrow camera through the neck of your womb. We're going to put fluid through the instrument into your womb to stretch it out. We're going to have a look inside and we're going to take a biopsy. Now, there are two settings under which hysteroscopy can be undertaken. And I strongly believe in patient choice and women's right to choose how they have intervention. And therefore, I offer my patients both options. So the first option is as an outpatient or awake, and that is done in an outpatient hysteroscopy clinic like the one I'm sitting in today. The second option is for it to be done in an operating theatre. And that is done either under regional anaesthesia, so for example, a spinal block, which is an injection into the back to numb lower down so that you don't feel the procedure, or a general anaesthetic. I will discuss both options, and then you can consider, if you're due to have a hysteroscopy, how you want to proceed. So I'll start with the outpatient option. Most women who have hysteroscopy have it as an outpatient, and the procedure is conducted exactly as I've described before. What are the risks of outpatient hysteroscopy? So the first risk to discuss with outpatient hysteroscopy is pain. So because, as I mentioned before, we fill your womb with fluid under pressure, the womb thinks it's having a big period. So you get crampy-like pain during a hysteroscopy. And in my experience, the severity of pain varies tremendously among women. So some women have the procedure and they chat to me like I'm doing now, and we have a full conversation, whereas some women cannot tolerate the procedure even for 1 second. The quoted risk of severe pain at outpatient hysteroscopy is 1 in 3 women. So 2 out of 3 women can tolerate the procedure, it's okay. 1 out of 3 can't tolerate the procedure at all. Unfortunately, it's difficult to predict which women will tolerate the procedure well and which women will find the procedure extremely painful. Some things we may look at is if women, for example, find it difficult to have vaginal examinations, find it difficult to have smear tests, etc., then they're probably not good candidates for outpatient hysteroscopy. Women who have had normal deliveries in the past or vaginal deliveries often will tolerate the procedure better. But having said that, some women who have had normal deliveries find the procedure very painful, and some women who've never had a baby tolerate the procedure very well. The last group, postmenopausal women, so women after the menopause, sometimes they can find the procedure extremely painful. But again, not all women who are postmenopausal find the procedure painful. Many are absolutely fine with the procedure. So it's difficult to determine which group any woman falls into. And this has to be understood before the procedure is undertaken. Of course, during the procedure, women are supported and are spoken to throughout the procedure. We always ask if it's too painful. We always ask if it seems too painful. We always ask if the patient wants us to stop. Or sometimes, we take the decision that, this is probably too much for the patient, and we stop because we think it's the right thing to do. In terms of pain relief for the procedure, we ask that our patient take whatever painkiller works well for them about an hour before the procedure. So generally speaking, that'll be paracetamol and ibuprofen. In addition, during the procedure, we have a warm pack, which is here, that we heat up and we place on the patient's abdomen during the procedure. Now, that doesn't sound particularly effective, but I can tell you it is really, really effective, and our patients really love this heat pack. The third option we have as standard is the option of gas and air. And we have that gas and air in the room for every outpatient hysteroscopy. So should a woman require it, need it or want it, it's literally just at the side of the bed for her. Again, in my experience, most patients don't use gas and air during outpatient hysteroscopy. I have to stress that the vast majority of patients choose the outpatient route, and the vast majority we succeed via that route as an outpatient, and patients are happy with this. The other risks are there is a risk of bleeding. So because we put water into the womb, then patients have a usually a watery loss, and that can last about a week to 2 weeks after the procedure. We ask that for that loss, patients use pads, not tampons, because tampons increase the risk of infection. Likewise, we advise against sex, swimming, or baths just until the discharge completely settles. There is a risk of taking infection with us, but it's a very small risk, so that we don't routinely cover this procedure with antibiotics. However, we do advise that if the discharge becomes funny in smell or colour, or if the patient feels a bit hot and cold or unwell, that she should contact either her GP or contact us, and then she can be seen and we can give antibiotics if appropriate. It is quite rare that heavy bleeding occurs during hysteroscopy, but it's not impossible. So I always mention and ask patients if they're okay to have a blood transfusion if there is heavy bleeding during the procedure. We generally only give blood in a situation of life-threatening bleeding, so it is extremely unlikely, but we always mention it beforehand because it's the right thing to do. There is a small risk of perforation, and that means puncturing the wall of the womb. So, as you can imagine, the womb is a closed, blind-ended organ like that. And what we're doing is we're putting the camera through the cervix or the neck of the womb. There is a small risk that the camera might go too far and puncture the wall of the womb. If that happens, the womb is made of muscle, and we know that it usually repairs itself with no long-term consequences. We may cover things with a course of antibiotics, just to err on the side of caution. The knock-on effect of perforation, however, is if we do puncture the womb, that means the tip of the instrument is now in the abdomen or in the tummy or in the pelvis, and in the tummy or pelvis lie other organs such as the bladder and bowel. So there is a small risk that if perforation or puncturing the wall of the womb happens, that there can be bladder or bowel injury. The risk of perforation is about 1 in 100. It doesn't happen frequently. The risk of injuring other organs, as you can imagine, is very much smaller than that. If, however, we even suspect that bladder or bowel has been injured at hysteroscopy, at outpatient hysteroscopy, we can't just leave that situation. We would take the patient to theatre. She would have a general anaesthetic, and we would perform either a laparoscopy, so that means keyhole surgery to have a look, or a laparotomy, which means a big cut on the tummy, and we would investigate and or repair any injury. The other risks are that when we put any instrument through the neck of the womb, so the hysteroscope, the biopsy sampler, or sometimes even coils, for example, opening the neck of the womb can cause a reflex, which can decrease the blood pressure a bit, decrease the heart rate, and patients can feel sick, dizzy, faint, and can sometimes faint during this procedure. That is much more likely to happen if you fast before the procedure. So we always advise that you have whatever is the appropriate meal. So in a morning appointment, have a good breakfast. In an afternoon appointment, have a good lunch before the procedure. Because sometimes ladies come along and they fast for the procedure because they're in their head, it's like they're having an operation and everybody knows you need to fast for an operation. So if you're having an outpatient hysteroscopy, do not fast because you're far more likely to faint. The last risk is failure. So we can never guarantee that we can complete the procedure on the day. So some reasons why we may not be able to complete the procedure on the day is if the patient is too uncomfortable, if it's too painful, then we stop, as I discussed before. Or perhaps if the cervix is too tightly closed and we can't get in, then that's a reason that we may stop and bring the patient in to have the procedure under general anaesthetic. failure is pretty uncommon at outpatient hysteroscopy. As I said, we usually complete the procedure if that's a decision that was made by the patient. Okay, the other option would be to come in and have the same procedure done in an operating theatre. So this is what we class a day case procedure. So she would come in on the day of the procedure, go to theatre, and depending on her choice and other considerations, for example, if she is unfit for a general anaesthetic, then a spinal anaesthetic might be more appropriate. And of course, patient's choice. Then she goes to theatre, she has her either spinal anaesthetic or general anaesthetic, and we perform the hysteroscopy. Now, I tell my patients that the risks of a hysteroscopy on the general anaesthetic are pretty much the same as having it done as an outpatient, because we're performing exactly the same procedure. There is a slightly higher risk of perforation on the general anesthetic, but this is probably likely because we perform procedures that we anticipate might be more difficult under general anesthetic, or as I mentioned before, if we are unsuccessful at outpatient hysteroscopy for whatever reason, then we do the same procedure under general anesthetic. So the cohort of patients that you start off planning a general anesthetic for are probably more complex and more complicated, and that probably explains to a great extent why the perforation rate is higher. The other risks, if one has the procedure under general anesthetic or regional anesthetic, of course, are risks associated with anesthesia or spinal anesthesia, but these are generally small because, as we know, anesthetics are very safe. There is a risk of blood clots in the legs and the lungs, so that's DVTs, but those risks vary depending on the individual patient. And we do take precautions to minimize those risks, such as putting special compression stockings on during the procedure and during the hospital stay, or perhaps giving some medication, some injections to thin the blood slightly to minimize the risk of blood clots. We anticipate, all things being equal, that patients who come in to have a hysteroscopy in operating theatre go home the same day. The same advice applies for having a loss for a week to two and use of pads, etc., etc. That advice is the same. The last risk for particularly having a general anaesthetic that I'm still mentioning is COVID risks. So if you have symptoms of COVID, I would recommend that you take, for example, a lateral flow test to make sure that you don't have COVID, because we know that the surgical and anaesthetic risks are increased if patients have COVID. So if that is a scenario, what we would advise is that we defer the operation until the infection has passed and settled down. So those are the options we offer, and that is what to expect if you're going along for a hysteroscopy. The choice is yours. There are also some centres who offer hysteroscopy under conscious sedation, so you can inquire about that. So thank you for watching. I'd be delighted to hear about your experiences with hysteroscopy if you've had one in the past, be it positive or negative, because we are always trying to improve our service to women, improve patient choice, improve patient education, because this is a partnership and we all want the same thing. We want our women to have a good service, to be diagnosed in a timely fashion, and to have the procedures in a way that is acceptable for them. Thank you for listening.